Yes.
Can I go back and ask a question about the Plavix?
Oh, yeah.
Does that mean that anybody on Plavix, you need to, if they're on a polypharmacy review, and see if any of those medications inhibit that CYP, or is it just with
The two C19 was
Yeah.
the biggie. And obviously we can look back and you know, it's one of those that I don't know, when did the whole P450 system really kind of come into play in medicine? It wasn't many years ago, and it's just been the bane of all of our existences ever since. Because no one can remember, you know, 3A, 4, and all this, and which drug does what, and which one inhibits it, and which one activates it, and so on and so forth. It wouldn't be a bad idea, because you can find tables and charts that say, okay, which drugs inhibit 2C19,
Right.
those are the ones that
should not be on if you're on Plavix?
well, at least you say that they have an increased risk.
Okay.
And again, with those, you know, you don't really know how effective the drug is at inhibiting 2C19. And I couldn't find any studies that say, okay, you know, if you've got a drug inhibitor of 2C19 versus a loss of functional allele, which one's worse?
Right.
And I don't know the answer to that. I'm not sure that the study's actually been done to see which is worse. But I bring this up to say that you know, we had always thought about these as you know, if you have a drug or you have an enzyme that doesn't work, it's not breaking the drug down properly, therefore you get increased exposure and subsequent problems with that. This is one where just the opposite is true, that you actually see less exposure because this enzyme is actually important in breaking the drug to an active form. But I think what it comes down to is that we have to rely on our pharmacy folks more and more to not just say, gosh, we think these drugs interact, but to say, gosh, you know, they inhibit specifically these components of the P450 system, and here's the end result of that, or the potential end result. Okay.
I know Dr. Doherty, you spoke a little bit about this, but considering you're living in the age where translational research happens and we have immunotherapy now, do we see it in foreseeable future, like the next 2 decades, that we will be counseling our patients about taking a gene test, or I mean, this is basic research at this point, but
it is, but I think that's got important applications, and I think what it comes down to, there are already genetic tests that we can do, Huntington's disease, for example, and that's one that comes with a whole bunch of potential emotional baggage. You know, in essence, you can give someone a death sentence if you say, yeah, you're going to get Huntington's disease, you're going to develop this. And so it I think becomes kind of a slippery slope to say, where do you draw the line? You know, is it reasonable to do genotypic analysis of someone's P450 enzymes, their hepatic metabolism potential? And that has real implications when you go to prescribe certain medications. You know, they're going to break it down really well or not at all.
But in breast cancer, where we're doing ER, PR, and Herceptin, and making our therapeutic decisions made based on that, I think it's going to look pretty similar to that, because I mean, we are basing our judgment on whether to give like Plavix or any other medicine related to this based on P450 system, if it ever comes into play.
It's kind of different because one is prognostic, whereas one is diagnostic. You're trying to predict with this P450, but the other one is more prognostic.
Right, but I mean, the pharmacy might, say that's card. I mean, if they can do that, why can't they do this? Because whoever makes a test for this will want to push it.
Well, if I could follow that, what's going to happen is that the insurance companies are going to force that, because it's not going to be cost effective for them to give drugs to people for long periods of time if they're not going to be effective. So they're going to force people to have the test, because it's cheaper to have the test and know whether the drug's going to be effective or not.
Well, and even to follow that one step further, even to say that is the drug going to be effective, is to say, gosh, what's the price of the test compared to 1 in 25 potentially having another heart attack, dying, or having a stroke? You say, wow, that's a pretty cheap test to save, to do 25 times to potentially prevent an MI. Most people, I think, would agree that that's probably going to be a reasonable trade-off, cost versus benefit. But you're right, you can see that very quickly eroding into, you must have this test before the drug is paid for, before we can decide which, to use this, to do that. So some very interesting, I think, implications way beyond, gosh, should we use Protonix instead of Prilosec for our patients who take Plavix. those Ps. You know, that's kind of the very scratch the surface part of it. However, if you take it a few steps further, I think the implications are very far-reaching. And even if you think, you know, just you know, a similar thing would be to, you know, being able to analyze someone's brain and the receptors to say, gosh, who's going to respond well to which antidepressant? But then it also says, are you doomed to develop depression or something else? So it's some interesting discussion. Any other points or questions?
I was going to say, there's some of this is going on a little bit because there have been some increasing pushing for like carbamazepine testing in, I think it's Asians, looking for specific variants that would predispose them to Stevens-Johnson syndrome. And so there is some recommendations coming down, even from the manufacturer, about doing that in Asian populations.
So in a population that's particularly high risk.
And it does tend to be, from what I know, Dion can comment, but from what I know, there does seem to be a higher difference in Asian populations in some of these allele changes having to do with the cytochrome system and some of these drug-related issues. Just like with Crestor, you have to watch with Asians because they don't metabolize it at the same rate. A lot of things that tends to be kind of the group of differences compared to a lot of the other races.
And the tough thing is that you say they don't tend to metabolize it at the same rate. And so we look at that and say, okay, you know, quantifying that tendency to say, you know, are you the, you know, say these Asians, the 40 or so percent that do metabolize it properly or metabolize it as we'd expect versus the 55% or more that don't. The other difficult thing then, of course, becomes where do you set that cut point to say, you know, who, you know, okay, if the allelic frequency or the frequency of the abnormal gene is 20%, does that make it worthwhile enough to do the test, or does it have to be 40, 50% gene frequency before it's worthwhile checking? So good. Well, thank you for an interesting discussion and for your attention. Anybody want to see Linda's letter?